Hello everyone. Welcome back to another session of Physiology discussion, INICT May 2024 recall session on Physiology. I hope the audio visuals are fine. Yes. So please do come in the chat box. So any comments or any feedbacks, if anything is good or not good also, you can feel free to post in the chat box. Yes, we'll just wait for one more minute and exactly at 7 we will start the session. Hello, Dr. Reddy sir. Hello, Dr. Arvaj. Bye. I'm just waiting for students to join. Just one more minute, we'll start the session. Okay. So I welcome you all to this physiology discussion on INICT May 2024 recall session. So first of all, I'm so happy to tell you that all the questions in physiology were from our NEET PG discussion videos on Manipal MedAce app. So I've done almost 45 to 50 hours of discussion on physiology videos, and all the questions are right straight away from our discussion there. So no twists or turns, direct questions from our discussion. And I can also tell you which part of the discussion videos we had these discussion on the topics, the questions that were asked from, and few of the questions I'm really happy that the exact question that we had discussed had appeared in the exam. So all of you who have watched Manipal MedAce Physiology NEET PG videos, definitely 100% strike rate, you would have answered all the question straight, right? Yes. So with me, Dr. Abhirami, your physiology faculty. Let's start off our discussion. Welcome Dr. Rahul, Dr. Abhishek Jha, Dr. Nandini, Dr. Satyaprakash. Welcome all of you. So first of all, let me tell you, there were around 10 questions, 10 to 12 questions from physiology in yesterday's INICT May 2024 exam, and all of them were easy to moderate type of questions. As far as physiology was considered, they were all easy to moderate type of questions. Maybe one question was on the tougher side, otherwise all of them were direct questions. And the other thing was, all of them were straightforward one-liner questions, not very clinically twisted questions. We didn't find any of the physiology questions too much of into clinical medicine. Medicine were separate questions, physiology was separate question. Usually what happens, medicine and physiology, you find a vast overlap of the stem of the question itself will have overlap between physiology and medicine. But this time INICT wasn't like that. It was not like that. Physiology separately you can identify physiology questions, and medicine questions separately you can identify medicine questions. There was a clear-cut differentiation between physiology and medicine questions. Actually it's a good thing, because if you have learnt two subjects separately well, answers you could have answered all the questions individually from both the subjects, physiology as well as from medicine. Yes, welcome. Students are still joining. Welcome. Welcome all of you. Over to the first question with that introduction. Yes, the first question was from renal physiology, exactly what we had learnt in renal physiology in this topic of GFR. The question was, which of the following decreases glomerular filtration rate? Which of the following decreases GFR? The options given were option A, increase in glomerular capillary hydrostatic pressure, decrease in glomerular capillary oncotic pressure, increase in renal plasma flow, and increase in Bowman's capsule hydrostatic pressure. The correct answer is increase in Bowman's capsule hydrostatic pressure. Let me show you this. Yes, this is a screenshot from Manipal MedAce, the NEET PG app. the chapter that was discussed, renal physiology, under the topic glomerular filtration rate. Yeah, it's me there teaching you physiology on Manipal MedAce app. So this is a direct screenshot from our Manipal MedAce NEET PG discussion videos in physiology. So in renal physiology, in this topic called GFR, we have exactly discussed all the forces which are involved, all the options that were given in the question, and I can give you the time frame also. Exactly at 13 minutes we had discussed this. 13th minute we had discussion on this. Yes, let's go on to the discussion of the question as such. Hydrostatic pressures and oncotic pressure. In the options you can see hydrostatic pressures and oncotic pressures. First of all, you should understand what is hydrostatic pressure and what is oncotic pressure. Only then you will be able to correlate the right answer for the question. Let's understand what is hydrostatic pressure and what is oncotic pressure. You can imagine hydrostatic pressure as a pushing force. What is hydrostatic pressure? Denoted by capital P. It's a pushing force. Have you played like this in the garden? Have you played with water hose pipes in the garden? When you try to pour water in your garden with a hose pipe, if I close half the nostril of the hose pipe, water will be pushed out with a great force. So hydrostatic pressures are pushing forces. They will always try to push the filtration to the other side. Wherever you have hydrostatic pressure, it is a pushing force. It will push the filtration to the other side. So hydrostatic pressure denoted by capital P, it is a pushing force. Oncotic pressures denoted by pi, it is a pulling force. How do we imagine or understand oncotic pressures? Oncotic pressures are contributed by plasma proteins, and plasma proteins, albumin, globulin, all the plasma proteins are like a sponge. If you place sponge in water, it will keep pulling water. So wherever you have plasma proteins, they are like a sponge. They'll keep pulling the water. They will pull the filtration to their side. So they are all pulling forces. Just remember this. Hydrostatic pressures are pushing forces. Oncotic pressures are pulling forces. So with that, easily we can solve this question. Now let's apply these pressures on the glomerular side and the tubular side. On the glomerular side, hydrostatic pressure and oncotic pressure. Similarly, on the tubular side, hydrostatic pressure and oncotic pressure. So let me put this in the form of a diagram. So this is the glomerular capillary side, and this is the tubule, the tubular side. So on the tubular side, so I can say the glomerulus covered by the Bowman's capsule continues as the tubule. So Bowman's capsule continues as the tubule. So I can say Bowman's capsule side or tubular side, both are same. So two sides we have. The glomerular capillary side, this is one side, and on the other side we have Bowman's capsule or the tubule. So I will apply the pressures accordingly. What is PGC? P for hydrostatic pressure, GC for glomerular capillary side. Pi GC, oncotic pressure on the glomerular capillary side. Similarly, on the tubule, T, pi T, oncotic pressure on the tubular side, and PT, hydrostatic pressure on the tubular side. I can use this word tubule or I can use this word Bowman's capsule. Both are same because the Bowman's capsule only continues as a tubule. So we can use, yes, hello Dr. Wondergrape, Dr. Meenakshi sir, welcome all of you to the session. Thank you so much for joining the physiology session. So tubular side or the Bowman's capsule side, both are same. Tubular side or Bowman's capsule side. So I can use this pi T or pi BC, tubular side or Bowman's capsule side, PT or PBC, all are same. Now let's understand that of these four pressures, two forces will favor filtration and two forces will oppose filtration. So what are the forces which favor filtration? It means what are the forces which help in your filtration? They will increase the filtration. The two forces which favor filtration, PGC and pi T. Because PGC is a pushing force, hydrostatic force, pushing force on the glomerular side. It would push the filtration into the tubule. And pi T, this is a pulling force on the tubular or Bowman's capsule side. It would pull the filtration into the tubule. So the two forces, PGC plus pi T, they are favoring forces. They are helping to increase the GFR. What are the two forces which oppose filtration, which oppose your GFR? Pi GC and PT or PBC. Because pi GC is an oncotic pressure pulling force on the glomerular side. So it will pull the filtration from the tubule into the glomerulus in the reverse direction. So this will decrease the GFR. PT or PBC, pushing force, hydrostatic force, but it's a pushing force on the Bowman's capsule side. So this will push the filtration into the glomerular capillary, again in the reverse direction. So these two are opposing forces. So let me write that. Pi GC and PT or PBC, they are opposing forces. So we know what are the two forces which favor filtration, PGC and pi BC. What are the two forces which oppose filtration, pi GC and PT or PBC? So with this, can you answer this question? Going back to the question, which of the following decreases glomerular filtration rate? Look at the first option, increase in glomerular capillary hydrostatic pressure. What will you have if you have an increase in glomerular capillary hydrostatic pressure? This will push the filtration into the tubule. That's why it is a favoring force. So glomerular capillary hydrostatic pressure will increase the GFR. Correct. So this is a force which increases GFR. What about glomerular capillary oncotic pressure? Option B, the glomerular capillary oncotic pressure. It is a pulling force. It will pull the filtration from the tubule into the glomerular capillary side. So it's going in the reverse direction, but the option is decreased oncotic pressure in the glomerular capillary. If you have more oncotic pressure in the glomerular capillary, it will decrease the GFR. So if you have less oncotic pressure in the glomerular capillary, it will increase the GFR. So this is a force which would increase your GFR. So this also increases GFR. Increased renal plasma flow, yes, more the plasma flow, more will be your filtration. This also increases GFR. What about the last option? Increased Bowman's capsule hydrostatic pressure. So on the Bowman's capsule side, if you have more hydrostatic pressure, which is PT or PBC, it is a pushing force. It will push the filtration into the glomerular capillary, thereby taking it in the reverse direction, and that's why it becomes an opposing force. So this would decrease your GFR. So GFR will be decreased by increase in Bowman's capsule hydrostatic pressure, which is denoted by PT or PBC. Both are same. PT or PBC. Both are same. Yes, very good evening, Dr. Jamina, Dr. Munmun Khan, Aniket. Welcome all of you to the session. So that was about the first question on renal physiology. Which of the following decreases GFR? Direct question. Increase in Bowman's capsule hydrostatic pressure. Over to the second question. From endocrinology, a man presented with thin skin, purple striae and non-healing wound. What is the most probable cause of this? The options given were hypothyroidism, hypercholesterolemia, hypercortisolemia and insulin resistance. The most appropriate answer, this is also a direct question, thin skin, purple striae, non-healing wound. Yes, it is Cushing's syndrome. Hypercortisolemia, which is significant of Cushing's syndrome. It's a patient of Cushing's syndrome and all the clinical features given clearly reflects Cushing's syndrome. So the answer would be hypercortisolemia. I'm so happy that this question also we have discussed in our Manipal MedAce app under physiology videos in this chapter of endocrine physiology under the topic adrenal gland. So exactly at 36-minute time frame, I've told you that this cortisol causes increased lipolysis. If it causes increased lipolysis, one of the action of cortisol is to increase lipolysis. More the lipolysis, it will cause lipolysis in the periphery and take all the fats to the center and deposit all the fat in the center of the abdomen. And that is why the patient presents with centripetal obesity. And if you have more deposition in your abdomen, the subcutaneous fat is more, it will stretch the skin, thereby causing purplish striae. So let me show you the slides also on Cushing syndrome where we had discussed about this. So if you can remember, if you have watched my videos there, I taught you an easy method to understand the actions of cortisol. What is Cushing syndrome? When a patient is exposed to excessive levels of cortisol, what are all the clinical features that you can see in this patient? So that is called Cushing syndrome. When we are exposed to excessive cortisol, hypercortisolemia, the feature is called Cushing syndrome. What are all the features of Cushing syndrome? Cushing syndrome patients have hair thinning. Why do they have hair thinning? Because whenever cortisol is in excess, another hormone from the adrenal gland, adrenal androgens, are also in excess, and that results in hair thinning and hirsutism, acne, plethora. Moon face. Why do Cushing syndrome patients have moon face? Because of excessive aldosterone activity. Whenever cortisol is in excess, it will start acting like mineralocorticoid. It will have aldosterone-like activity. What is aldosterone-like activity? Salt absorption, salt retention. Aldosterone causes salt retention. Salt retention will pull water also. So this will cause water retention. More the water retention, excessive accumulation of water, this can cause swelling, edematous appearance of the face, which is called moon face appearance. Cushing syndrome patients have hypertension. That is also because of salt retention due to aldosterone effect. Mineralocorticoid-like effect causes salt retention, and salt retention will cause hypertension. What are the other features of Cushing syndrome patients? Cushing syndrome patients have peptic ulcer. What is the reason? Because cortisol has a tendency to increase gastric acid. Cushing syndrome patients have loss of height, back pain, and compression fractures. They have callus with fractures, osteoporosis, all bone related disorders. Why do Cushing syndrome patients have bone related disorders? That is because the action of cortisol is to increase osteoclast and to decrease osteoblast. Bone destroying cells are increasing and bone forming cells are decreasing. That is why they experience bone related disorders. And Cushing syndrome patients have menstrual disturbance because the action of cortisol is to decrease gonadotrophins. LH is decreased and FSH is decreased. Very good evening, Dr. Vignesh. Yes, Dr. Aniket has a doubt. Ma'am, how should I utilize Guyton for concept building and PG preparation? Is it enough? Yes, definitely, Dr. Aniket. Please wait till the end of the session because students are waiting. I'll finish the session. Once the session is done, definitely I'll come back to you, Dr. Aniket. We'll discuss that also. Yes, welcome, Dr. Bhavani Anand. So that was about menstrual disturbance in Cushing syndrome patients. Cushing syndrome patients have a tendency for infections. Yes, this was there in the option in the stem of the question. We saw this tendency for infections with poor wound healing and little inflammatory response. Why do they have infections and poor wound healing? Because cortisol has a tendency to decrease all the inflammatory mediators like eosinophil, lymphocyte, interleukins and phospholipase 2. All these are inflammatory mediators and they are all decreasing. Inflammation is good or bad? Yes, inflammation is good. Only if you have inflammation, inflammatory mediators are attracted and that is when wounds get healed. But if cortisol is decreasing inflammatory mediators, patients have little inflammatory response and therefore poor wound healing. Wounds are not healing. Poor wound healing. So that was there in the stem of the question, poor wound healing and little inflammatory response. What are the other features of Cushing syndrome patient? Bruising of skin. Yes, why there is bruising of skin? Because cortisol will decrease fibroblast proliferation. Skin cells, only if fibroblasts are proliferating, wounds will heal. That's why they have many unhealed wounds on the skin, which is called bruising. Other features of Cushing syndrome patient. Cushing syndrome patients have psychosis because cortisol tends to increase EEG rhythm. Electrical activity of the brain is increasing. That's why these patients experience psychosis. Cataract. What is the reason for cataract in Cushing syndrome patients? This is mainly because of drug-induced exogenous Cushing syndrome, which is because of excessive steroid therapy. Posterior subcapsular cataract is common. Cushing syndrome patients have decreased skin thickness. Yes, that was there on the question. You remember the stem of the question had this thin skin. Why do they have thin skin? Wasting and weakness of the proximal muscles, because the action of cortisol is to increase proteolysis. If proteolysis increases, more proteins are broken down. If muscle proteins are broken down on the skin and muscles, if proteins are broken down, automatically the patients will go for decreased skin thickness. What will happen if proteins are broken down? Amino acids are released. More the amino acids, they enter into the liver. Amino acids in the liver can be converted into glucose. This we call it as gluconeogenesis. So Cushing syndrome causes gluconeogenesis, and that is why Cushing syndrome patients are more prone for hyperglycemia. So Cushing syndrome itself is a diabetogenic state because more glucose is synthesized. That is the reason for hyperglycemia in Cushing syndrome. Plasma proteins are increased. Why plasma protein levels are increased? More the amino acids enter into the liver. Some of the amino acids are converted to glucose and some of the amino acids are converted to plasma proteins. That is why muscle proteins are broken down but plasma proteins are synthesized. What is the effect of cortisol on lipids? Lipolysis. More lipids are broken down. More the lipids are broken down, especially in your hands and legs, lipids are broken down. They are taken to the center of the body and deposited on the center of the abdomen. This is called centripetal obesity. Hands and legs will be very thin, but center abdomen is obese. Centripetal obesity. If there is excessive fat deposition under the skin, it will cause stretching of the skin. This results in purplish stretch marks. So that was about the clinical features of Cushing syndrome along with actions of cortisol. Going back to the question, now I think you will know the answer for the question. A man presented with thin skin, purplish striae, non-healing wound, typical of Cushing syndrome. So the best answer would be, or the only answer would be, hypercortisolemia. Over to the next question from neurophysiology. EEG shows K complex. I think there was an EEG image, the graph which had K complex, or I'm not sure if it was in the sentence form, but EEG shows K complex. Identify the stage of sleep. Direct question. Sleep spindles and K complexes appear during NREM stage 2. Let's discuss this. Yes, happy to share the screenshot from our NEET PG videos on the app, Manipal MedAce app for NEET PG. So we have already discussed this under the chapter neurophysiology, under the topic sleep physiology. Exactly, this is the point where I had discussed about sleep spindles and K complexes. Yes, going back to the discussion on sleep physiology, and then we'll go back to the answer for the question. Two types of sleep: REM sleep and NREM sleep. Rapid eyeball movement sleep and no rapid eyeball movement sleep. Usually we start sleeping in NREM sleep, no rapid eyeball movement sleep. So that's why when you say good night and you go to sleep, you are in NREM sleep. When you say good morning and you get up in the morning, we get up from REM sleep. But throughout the night, what happens? There is a switch over between NREM, REM, NREM and REM. Every 90 to 110 minutes, this switching over happens. And this we call it as ultradian rhythm. So overall, if you calculate, 75% of the sleep you would have spent in NREM sleep and 25% of the sleep in REM sleep. So that is about NREM and REM. So now let me show you the sleep waves that are recorded in EEG. When you do an EEG by connecting electrodes all over the scalp and you record the electrical activity of the brain, you can diagnose various sleep disorders. If you think of any sleep disorder in a person which has happened in NREM, or you think it might have happened in the REM sleep, to get a clear diagnosis, you just perform an sleep EEG, ask the patient to sleep, and you record the electrical activity of his brain throughout the night until he gets up in the morning. With that, you will be able to diagnose sleep disorders, because throughout the night, throughout your sleep, there are different types of waves that are recorded from your brain. Let me show you what are the different types of sleep waves in EEG. So this is exactly the slide from which we had discussed in our Manipal MedAce app on physiology videos. The same slide I'm showing you. Sleep waves. One mnemonic, easy mnemonic to learn this. At night, bats drink blood. At night means we are recording the electrical activity of the brain during the night. Bats drink blood. Let me arrange that. B A T S. Bats drink. D blood. B. BATS drink blood. B for beta wave, A for alpha wave, T for theta wave, S for spindles and K complex, D for delta wave, and B for again beta waves. How do you sleep? When you go to bed, immediately when you sleep? No. First, we stay awake for some time and eyes are open. Just imagine you're going to sleep. You go to the bed, you will stay awake for some time with your eyes open. At that time, your brain records beta waves. Then you close your eyes, you're relaxed, you haven't slept, but you're just trying to sleep. Now your brain will record alpha waves. Now only you enter into actual phases of sleep. NREM 1 where you get theta waves, NREM 2 where we record spindles, sleep spindles along with K complexes. So here you can see sleep spindles along with K complexes. And NREM 3 sometimes merged with NREM 4 also. D for delta waves and D for deep sleep. D for delta wave and D for deep sleep. And finally we have REM sleep where you record B for beta waves. REM sleep is called paradoxical sleep. Why is it called paradoxical sleep? What is the paradox here? What is the meaning of a paradox? Paradox means something which is weird, something which is controversial, which is not agreeing is called as a paradox. What is not agreeing here? What is the controversy here? Usually, beta waves are recorded when you are awake and eyes are open. But you get the same beta waves when you are sleeping in REM. That's why REM is called paradoxical sleep. So from here it is clear that NREM 2 spindles and K complex. So let me show you some other features, associated features of NREM 1, 2 and 3. NREM 1. The patient experiences hypnic jerks. So this is more common in children. In meditation and in depression, sleep spindles, NREM 2, bruxism happens in NREM 2. And overall, if you see, 50% of the sleep we spend in NREM 2. 50% of the sleep is in NREM 2. NREM 3 and NREM 4. D for delta waves and D for deep sleep. D for delta wave and D for deep sleep. So NREM 3 and 4 is called deep sleep. Sleep walk enuresis. Walking enuresis. Walking is somnambulism. People walk during the night at NREM 3 and NREM 4 sleep. Enuresis. Children are micturating during the night during NREM 3 and 4. People experience sleep tremors during NREM 3 and 4. And REM sleep. During the REM sleep, you experience penile luminescence. Early morning erections happen in REM sleep. So these are the special features of the sleep waves in EEG. Going back to the question. EEG shows K complex. Identify the stage of sleep. So it's clearly NREM 2. Over to the next question. Question number 4. Identify the hormones produced from the given zones. So what are the given zones? I think some image like this was given. Mainly the adrenal cortex and adrenal medulla was depicted. In adrenal cortex, the 3 layers were depicted. Some A, B, C markings like that. So I think it was like this. A was glomerulosa, B was fasciculator, C was reticularis and D was medulla. If I am not wrong, these were the options that were given. So from this, let's identify what are all the hormones produced by different layers of the adrenal gland. So happy to share this screenshot where we had discussed the same diagram with the same question had been discussed in our discussion in our app, the physiology videos under the chapter endocrine physiology under the topic adrenal gland, we had discussed the same image with GFR and the related hormones. Yes, so let me show you the slide of discussion. What are the layers of the adrenal gland? Adrenal cortex has 3 layers. The mnemonic is GFR. Zona glomerulosa, fasciculata and reticularis, and deep inside you have medulla. What are the hormones produced? GFR for salt, sweet and sex. GFR, salt, sweet and sex. What is that salt hormone? Aldosterone, mineralocorticoid. So zona glomerulosa produces mineralocorticoid aldosterone. Which is a sweet hormone? Cortisol, glucocorticoids. Which is a sex hormone? Adrenal androgens. So salt, sweet and sex for GFR. Those are the hormones of adrenal cortex. What about the medulla? Adrenal medulla produces catecholamines. What are the catecholamines? Norepinephrines, epinephrines and dopamine, metenkephalins, adrenomedullins. So that was about the answer to the question. I think option B was the right one. A aldosterone, B cortisol, C androgens and D was epinephrine. Yes, welcome Dr. Kaushalya, Mahalik and Vinit Shanmugam. Welcome to the discussion. Question number 5. Which of the following is seen in UMN lesion? Upper motor neuron lesion. So there was a controversy on the options given. Students were not able to clearly recollect the options. So as far as the information that I had received from students, they said muscle atrophy was there in the option, fasciculations were there. Some said spasticity, some said rigidity and exaggerated reflexes. So we are not here to exactly frame the questions, but to clear your concepts on UMN and LMN. So whatever could be the options, let me give you clarity about UMN and LMN diseases and what are the typical clinical features. So if the question is this, which of the following is seen in UMN lesion? So which of the following will be seen in UMN lesion? The answer would be spasticity, exaggerated reflex and rigidity. All three are seen in UMN lesions, whereas muscle atrophy and fasciculations are features of lower motor neuron lesions. First, let's understand what is UMN and what is LMN. So this also, I have placed a screenshot from our Manipal MedAce app for NEET PG under the chapter Neurophysiology in Motor Nervous System topic. So where we had discussed around the 22nd minute, I told you about the UMN diseases and the features and LMN diseases and the typical features. So let me recollect that again for you. UMN disease, upper motor neuron disease, and LMN is lower motor neuron disease. First of all, what is upper motor neuron? The neurons which are up are called upper motor neurons. Neurons which are low are called lower motor neurons. So what are the upper motor neurons? From brain to spinal cord, they are called upper motor neuron. From spinal cord to muscle, they are called lower motor neurons. So the upper motor neurons are your pyramidal tracts and extrapyramidal tracts. They are the upper motor neurons. Which is the upper motor neuron disease? Corticospinal tract lesion is a very common typical upper motor neuron disease, which is otherwise called pyramidal tract lesion, or it's otherwise called as hemiplegia. So this is an upper motor neuron disease. Lower motor neuron disease, poliomyelitis and spinal muscular atrophy. These are lower motor neuron diseases. What are the typical features of upper motor neuron disease and lower motor neuron disease? Can you recollect how did we learn this? Yes, the mnemonic upper motor neuron, up. What is up? Three things are up. Tone is up, hypertonia. Reflexes are up, hyperreflexia. And toes go up, which is called Babinski positive. Lower motor neuron disease, LMN, low. What is low? Tone is low, which is called hypotonia. Reflexes are low, which is called hyporeflexia, and toes go low. This we call it as Babinski negative. So these are the features of UMN and LMN lesions. So what is in the option given? Muscle atrophy, lower motor neuron lesion. Typically, muscle atrophy is seen in lower motor neuron lesion because What is a lower motor neuron? The neurons which are innervating the muscle. So if this is a muscle, if the neuron innervating this muscle is gone, the muscle is not functioning. So it will go for atrophy. So definitely muscle atrophy is seen in lower motor neuron lesion. Fasciculations. Fasciculation means small flickering movements. In lower motor neuron disease, the muscle cannot move because the nerve innervating the muscle itself is gone. So the muscle cannot move. But individual muscle fibers, they would flicker like this. Because of previously stored acetylcholine pockets which are released suddenly, you can see a flickering movement like this. That is called fasciculation. Please remember, muscle can't move, but individual fibers here and there, they will flicker. This is called fasciculation. So muscle atrophy and fasciculation typically seen in lower motor neuron disease. What is spasticity? When you have increased tone in the muscle, this will present as spasticity or rigidity. Hypertonia is of two types, spasticity and rigidity, but both are hypertonia. Both can be seen in UMN disease. Exaggerated reflex. Yes, in UMN disease, upper motor neuron disease, reflexes are exaggerated. So if this was the question and if these were the options, then we can go for spasticity, exaggerated reflex, rigidity. All three are seen in UMN lesion. Since we are not very clear about the options, so I'll just make it clear that we are just learning the UMN and LMN lesion differences. So whatever may be the option, the concept is this only. Muscle atrophy, fasciculation seen in LMN, spasticity, exaggerated reflex and rigidity are seen in UMN. So over to question number 6. All of the following are properties of ventricular muscle fibers except. Ventricular muscle means your cardiac muscle fiber. See, this is a very simple logic. Even if you don't know anything about ventricular muscle fiber, just applying logical thinking, you can answer this. Tetany. What is tetany? Spastic contracted state is called as tetany. Can your heart muscle go for spastic contracted state? What will happen if heart goes for spastic contracted state? It will not beat. The patient will die. So heart can never go for tetany. If your heart goes for tetanus, it means it has stopped beating. The patient will die. So in a properly functioning ventricular muscle, it can never go for tetanus. And the reason for that is it has a long refractory period. Just look at this here. I'm happy to share the screenshot from our app where I have discussed about cardiac muscle action potential. And in detail, I told you about this plateau phase. So the plateau phase only is prolonging the refractory period. Because of this plateau phase only, long refractory period, because of long refractory period, it is not going for tetanus. So quickly, let me recap the cardiac muscle action potential for you. This is nerve action potential, where depolarization is due to sodium influx and repolarization is due to potassium efflux. That is nerve action potential. What is cardiac ventricle action potential? What is special about cardiac ventricle action potential? Same like nerve, depolarization is due to sodium influx and repolarization is due to potassium efflux. But the special feature of cardiac ventricle action potential is in between depolarization and repolarization, it has a plateau phase, a flat phase. This plateau phase has no electrical activity. Why there is no electrical activity? Because of opening of L type of long-lasting calcium channels. See, during repolarization, usually what happens is potassium moves out, potassium efflux. So potassium efflux has started in phase 1 itself. There is complete potassium efflux in phase 3. But in between what happens, there is opening of long-lasting calcium channels through which calcium enters inside. Calcium enters inside. Potassium, one positive ion is moving out and calcium, one positive ion is moving in. Both these positive ions balance each other, and that is why there is no electrical activity during this period and it becomes a plateau phase. And since the plateau phase is very long, this is responsible for the long refractory period of cardiac ventricle, and that is responsible for the tetany not happening in the cardiac muscle. If the refractory period is more, refractory means it is not responding. So the periods during which the muscle is not responding is more, tetany cannot happen. Going back to the question, Length tension relationship. Yes, length tension relationship. It happens in skeletal muscles and also in cardiac muscle. Long refractory period. Yes. All or none law. Yes, because cardiac muscle forms a syncytium. The muscle will contract and relax together. It will form proper action potentials which will follow all or none law. And tetany is not seen in ventricular fiber. So the answer is all of the following properties of ventricular muscle fibers except tetanus. Cardiac muscle will never go for tetany. Patients will die if cardiac muscle goes for tetany. Over to question number 7. Erythropoietin is produced by. So this also we had discussed. Almost 90% of erythropoietin comes from interstitial cells of your kidney. In kidney, they are called interstitial cells of the kidney, and remaining 10% can come from your liver also. So kidney and liver, definite options. Spleen, there are papers which say little of erythropoietin can come from spleen also, but it is not a very important organ for erythropoietin, and heart does not produce erythropoietin. So if you want to select the correct answer from the options below, I can go for A only, B only, A and B. Yes, which one is best? We can choose A and B. Anyways, A, B and C is not there in the option, so we need not get confusion with the spleen. Even if spleen is an answer, you would have had an option of A, B and C. That's not there, so let's leave it. A and B. Kidney and liver, they produce erythropoietin. Most important source of erythropoietin is the interstitial cells of the kidney. 90% of erythropoietin comes from interstitial cells of the kidney. Question number 8. Identify the hormones represented by the following image. And this also, students are not very clear about the exact image. So as far as information that I have received from students, there was some image like this, where you had hypothalamus represented and pituitary gland and the liver. From hypothalamus, A and B, two hormones. So one is inhibiting pituitary, the other is excitating the pituitary, and pituitary is producing a hormone. This goes to the liver, acts on the liver and produces D. So the most appropriate answers could be option A. Hypothalamus produces growth hormone, inhibitory hormone, which is somatostatin, which is having an inhibitory effect on the pituitary. And B could be growth hormone releasing hormone, which has an excitatory effect on the pituitary, because somatostatin inhibits the pituitary effect of growth hormone, and growth hormone releasing hormone increases the pituitary effect of growth hormone releasing, and pituitary gland releases growth hormone. So C is growth hormone. Growth hormone enters into the liver. In liver, growth hormone is converted into somatomedin C, which is otherwise called insulin-like growth factor. Somatomedin C or insulin-like growth factor. Most of the effects of growth hormone are because of somatomedin C or insulin-like growth factor. That is why if you have any defect in growth hormone, the patient is a dwarf. That is called dwarfism. But if you have any defect in somatomedin C also, the patient is a dwarf. That is called Laron dwarfism. So one of the cause for Laron dwarfism is deficiency of somatomedin C or insulin-like growth factor. So from this, A could be somatostatin, B could be growth hormone releasing hormone, C could be growth hormone, and D could be somatomedin C or insulin-like growth factor. Hence, I go with this option, option B. A is statin, B is GHRH, C is GH, and option D is insulin-like growth factor 1. Over to question number 9. Identify the correct sequence. Yes, this also, I'm so happy to share the screenshot from our app where we had discussed the exact question in G protein coupled receptors. All the three mechanisms we had discussed, and the question is exactly on this. You can find this video in the chapter Endocrine Physiology under the topic Mechanism of Action of Hormones. So I'll show you this exactly at timestamp of 5.44 minutes. You can see this. So let me discuss quickly G protein coupled receptors and the mechanism of action of G protein coupled receptors. G protein coupled receptor is a cell membrane receptor. There are three mechanisms of action for GPCR. The first mechanism of action, production of adenylyl cyclase, and adenylyl cyclase produces cyclic AMP, and cyclic AMP produces protein kinase A. This is the A pathway. A for adenylyl cyclase, A for cyclic AMP, and A for protein kinase A. And the second pathway is guanylyl cyclase, production of guanylyl cyclase. Guanylyl cyclase produces cyclic GMP, and cyclic GMP produces protein kinase G. This is the G pathway. G for guanylyl cyclase, G for cyclic GMP, and G for protein kinase G. And the third pathway, production of phospholipase C, and phospholipase C can convert PIP to phosphatidyl inositol bisphosphate into IP3 and DAG. IP3 releases calcium and DAG releases protein kinase C. This is the C pathway. C for protein phospholipase C, C for calcium, and C for protein kinase C. So with this, can you answer this question? Yes, the correct answer is option C. Adenylyl cyclase, then cyclic AMP, and then protein kinase A. Very direct question, very easy, simple question. Over to question number 10. In response to increased blood pressure, which neurotransmitter is released at the SA node? So I think the question is about baroreceptor. They want to check if you know baroreceptor reflex. So quickly, I'll take you to the baroreceptor reflex. Yes, this also we had discussed in our NEPG videos in chapter cardiovascular physiology under the topic cardiac output and blood pressure. So this is where I told you about the effect of baroreceptors, how it is activating the parasympathetic and inhibiting the sympathetic. By now you should know the answer. The baroreceptor reflex, when BP increases, it will activate the parasympathetic, inhibit the sympathetic. If you activate parasympathetic, vagus, so the answer is acetylcholine. So let me quickly take you through this baroreceptor reflex. What is baroreceptor reflex? Baro means pressure. Whenever there is any change in the blood pressure, so any rise in blood pressure would be sensed by the baroreceptors. What are the baroreceptors? Aortic arch receptors and carotid sinus receptors. From the aortic arch receptors, this would trigger vagus nerve, and from the carotid sinus, this would trigger glossopharyngeal nerve. Both these nerves, they take these impulses into the brainstem, especially medulla. And in medulla, the center for controlling BP is nucleus tractus solitarius. What is the effect of nucleus tractus solitarius? It has two actions. It can activate the parasympathetic nucleus, which is vagus. The neurotransmitter is acetylcholine. And it can inhibit the sympathetic nucleus, which is your vasomotor center. And therefore, it inhibits the sympathetic components, epinephrines and norepinephrines. If you activate vagus, what is the effect of vagus on blood pressure? Parasympathetic. Parasympathetic is activated, sympathetic is inhibited. Yes, obviously BP would decrease. This is called baroreceptor reflex. How? An increase in BP through baroreceptor reflex causes decrease in BP. And the mechanism is activation of vagus, inhibition of sympathetic nucleus. So if vagus is activated, yes, acetylcholine would be increased. That is why we go for the answer acetylcholine. All others are sympathetic. Sympathetic is inhibited. So it's not norepinephrine, epinephrine or dopamine. It is acetylcholine. Over to the next question. Question number 11. Which hormone does not play a significant role in utero growth? So in utero growth, inside the uterus, in a fetus. See, actually, all of the given options are important for in utero growth. Insulin plays a very important role in fetal growth. Thyroid hormone, they also play a very important role in fetal growth. That is why congenital hypothyroidism, cretinism, cretin babies are dwarf. Insulin like growth factor, very important for fetal growth. Growth hormone is also important for fetal growth, but of the given 4 options, if you have to rule out one, you can take away growth hormone, because the more important effects of growth hormone is after the birth. It has effect in the fetus also, but if you have a question like this and you have to choose between 4, we can choose growth hormone. Does not play a significant role in utero growth, we'll go for growth hormone. Yes, we had discussed this also in our discussion videos in chapter endocrine physiology under the topic growth hormone. So I told you that growth hormone has its main effects after the birth. See, from birth onwards, the most significant effects of growth hormone. It also has its effect in fetal life, do remember, but not very significant, as insulin, thyroid hormone and insulin like growth factor very important. Growth hormone after birth, it is very important. Yes, over to question number 12, the last question. Students were not able to properly recollect this question because I think there was an overlap with physiology and also medicine. But with the options that I had received from students, they said ECG was given with ST depression in leads V2, V3 and V4. Just with this and the given options, NSTEMI, myocarditis, etc., etc. Since options we are not able to recollect thoroughly, I can give you an idea. I can give you a clarity on ST depression and the leads that you identify. See, ST depression means it is called NSTEMI. No ST elevation MI is ST depression. So here we can go for NSTEMI because the question is not very clear. Just with ST depression, especially V2, V3, V4 denotes anterior leads. So it could be an anterior wall NSTEMI. So let me just give you an idea of STEMI and NSTEMI and the leads that you identify. So we had discussed this also in our discussion videos where we discussed about STEMI and NSTEMI where you find ST depression. So let me give you an idea about this. ST segment. ST segment, 2 types of defects possible. ST elevation or ST depression. Usually in an subendocardial ischemia, when it is a developing ischemia, ischemia means loss of blood supply only. It is reversible. You find ST depression. So as in this, there is ST depression. This is ST and there is ST depression. If a subendocardial ischemia develops into a full thickness infarct, if it goes for a transmural or full thickness infarct, then you get ST elevation MI. ST segment is elevated. This we call it as STEMI. So STEMI and NSTEMI. STEMI is ST elevation MI and NSTEMI is no ST elevation MI, which is ST depression. And a word about the leads. So if you want to identify the leads V2, V3, V4, V5. These are chest leads which clearly indicates anterior wall is involved. If you see changes in lead 2, lead 3 and AVF, clearly it is inferior wall. Inferior wall has been involved. So since in the question it is V2, V3, V4 and there is ST segment depression, we can go with NSTEMI of the anterior wall. But still we are not clear about the other remaining options. Definitely it's not myocarditis. So that was about the ECG question with ST segment depression. With that, we complete our session on INICET May 2024 Physiology discussion questions. I'm very happy to share with you that we have 100% strike rate on physiology from Manipal MedAce app, where I have discussed 45 hours of physiology videos and all the questions are from our videos. So please go back to the app and watch the complete videos so that students who are attempting for NEET PG exam, definitely you're going to have 100% strike rate in NEET PG also. So do come back to our app to watch the videos, to watch my videos. So thank you so much and never lose hope. Just think of this: when the sun goes down, That is the time when the stars come out. So don't worry about the sun going down. Definitely the stars will come out. Thank you so much. Yes, thank you, doctors, for watching this session. Any comments you have or any questions to be added, any options to be added? Yes, you can come to the chat box. Thank you, Dr. Vignesh. Yes, coming back to Dr. Aniket. Now I'm in first year. I did not cover concepts of physiology. I started with Guyton but shifted to Nikurana. I'm not confident about the concepts. Cover Guyton. Yes, Dr. Aniket, this is for you. It is not about reading Guyton or or Nikurana or whatever book it is. You should have a thorough knowledge of whichever you are learning. So Guyton you can read. It's a very nice book with lot of concepts, and if you really want to understand concepts in physiology, please do go with Guyton. Definitely you will be able to understand the concepts. But one thing I can tell you is, for first year students, it's very difficult to pass their university exam by reading Guyton. It's a wonderful book, but you will not be able to recollect points from Guyton. So as a first year student going for the exam, don't rely only on Guyton. You can use other sources also. But if you are a student who have passed the first year and you want to really understand Guyton, yes, Dr. Anike, this is for you. Definitely you can go for concepts in Guyton. And I can also suggest you, please follow our Manipal MedAce app videos, where we are posting physiology discussions. Lot of important concepts I have discussed, and also in our app, interesting concepts we are discussing in a very easy way. Yes, I think your doubt is clear, Dr. Aniket. Yes, definitely you can go with Guyton. Go back to Guyton. You can learn and understand concepts clearly from Guyton. Rather than any other book, Guyton will give you a clear understanding of concepts in physiology. Thank you, Dr. Aniket. Thank you, all of you.